Adipose tissue is often categorized as a passive thermal blanket or metabolic dumping ground. In reality, it's a highly active, system-wide endocrine organ at the center of human nutritional homeostasis. To understand the complexity of this tissue, we will deconstruct it block by block, starting with its microscopic architecture. Analyzing fat as a communicative organ provides the necessary context for understanding the metabolic drivers behind diabetes and heart disease. This flowchart illustrates the origin of fat cells. All adipocytes develop from mesenchymal stem cells, which branch into two pre-adipocyte lineages. The lateral mesenchymal lineage matures into white adipocytes, specialized for long-term storage. The periaxial lineage produces brown adipocytes, designed for rapid energy utilization. This early embryonic divergence dictates whether the mature cell will hoard energy or consume it. We'll begin at the microscopic level with mature white adipose tissue, or WAT. These micrographs show typical WAT in standard H&E sections. The unilocular cells are occupied by a single lipicaplet measuring 50 to 150 micrometers, which displaces cytoplasm and forces the nucleus against the membrane, creating a signet-ring appearance. Students should note these cells appear empty because standard techniques use xylene, which dissolves lipid, leaving only a cytoplasmic rim. Fixing tissue with osmiox hydroxide preserves lipids, staining them black and showing the central vault is full. This unilocular morphology allows the white adipocyte to maximize its storage volume, making it the body's most efficient long-term energy reserve. The storage process begins when triglycerides arrive via the bloodstream, packaged in chylomicrons or VLDLs from the liver. At the capillary wall, lipoprotein lipase hydrolyzes these complexes. The free fatty acids enter the adipocyte and are reesterified into triglycerides for storage. Mobilization is triggered when sympathetic nerve endings release norepinephrine, signaling a systemic fuel requirement. This activates hormone-sensitive lipase inside the cell, breaking down stored triglycerides into free fatty acids that diffuse into the blood and bind to albumin for transport. While managing these lipid levels, white adipocytes also secrete leptin. This 16 kilodalton hormone travels to the hypothalamus to act as a satiety signal. A common clinical observation in obesity is leptin resistance. While these patients produce high levels of the hormone, their target receptors are unresponsive, which negates the satiety signal. This demonstrates that white fat is a responsive chemical bank that constantly reports energy levels to the brain. Brown adipose tissue, or BAT, represents the opposite metabolic strategy. Making up 2 to 5% of a newborn's weight, it's critical for thermoregulation. Microscopically, BAT is multilocular. Instead of one large vault, the lipid reserves are divided into numerous small droplets scattered through the cytoplasm. This architectural shift allows the nucleus to remain spherical and centrally located within the polygonal cell. As shown in this diagram, the tissue's brown color comes from an extreme density of mitochondria containing cytochrome pigment, which are packed between the lipid droplets. By prioritizing mitochondrial density over storage volume, the brown adipocyte is optimized for generating heat. The primary function of brown fat is non-shivering thermogenesis, a process that directly warms the locally circulating blood. Just as in white fat, norepinephrine activates hormone-sensitive lipase to liberate fatty acids from the stored droplets. However, instead of exporting these fatty acids, the brown adipocyte immediately metabolizes them within its own mitochondria. This process relies on uncoupling protein 1, or thermogenin, a transmembrane protein in the inner mitochondrial membrane. Normally, the electron transport chain creates a proton gradient to drive ATP synthesis. UCP1 allows these protons to flow back into the mitochondrial matrix, bypassing the ATP synthetase complexes. This effectively short-circuits the process, dissipating the energy as heat. By uncoupling oxidation from phosphorylation, brown fat converts stored lipids directly into systemic heat. These cellular and embryological patterns are directly visible in the clinical presentation of obesity. Adult-onset obesity is primarily characterized by hypertrophy. Existing unilocular white adipocytes expand in diameter to accommodate surplus triglycerides. Childhood obesity frequently involves hyperplasia. In this state, mesenchymal stem cells are signaled to differentiate into new, permanent pre-adipocytes, increasing the total cell count. This has significant clinical implications. Caloric restriction can reduce the volume of individual cells, but it cannot eliminate the excess number of adipocytes created through hyperplasia. Anatomical distribution also influences metabolic risk. While subcutaneous fat is relatively stable, increased visceral fat in the abdomen is linked to higher rates of disease. Visceral fat is more metabolically dangerous because it releases pro-inflammatory cytokines directly into the portal circulation of the liver. These cellular lineages can also develop into specific types of tumors. Benign tumors of white fat are called lipomas and are quite common, while their malignant counterparts, liposarcomas, are rare. A benign tumor arising from fetal brown fat is specifically referred to as a hibernoma. Because brown fat is so metabolically active, surviving deposits in adults can appear as bright hypermetabolic spots on PET CT scans. Correctly identifying these deposits in the neck and supraclavicular regions is necessary to avoid misdiagnosing them as metastatic cancer. We have followed the adipocyte from its mesenchymal origins to its final form as either a storage vault or a thermogenic furnace. Mastering these fundamental histological blocks clearly demonstrates that adipose tissue is actually the central coordinator of human metabolic homeostasis.